Hello everyone, this is Rupan Kundu. I am one of the internal medicine residents at the Cleveland Clinic Hospital. Today I'm going to be discussing about how to write an HnP, how to present a case to an attending. Usually in the US we go for SOAP format, subjective, objective, and assessment and plan. For subjective, you usually do history of present illness, and then you do like past medical history, you do review a system. So I'll go through all of those in a bit. For subjective, what you usually do is you go and ask the patient about their current medical conditions and also the past medical conditions. For example, a patient is coming in with diarrhea. So whenever you think about diarrhea, you think about like, oh, is it infectious? Is it any other type of diarrhea? How long has this been going on and stuff? So you have to ask all of those questions and write those down. So, for example, the first line you will write in the history of present illness is the patient is like a 27-year-old male presenting here with a cheap complaint of diarrhea. That's it. Then you will write a brief past medical history. For example, just like making up situation. For example, this patient had some cancer and has been getting chemotherapy, and probably last dose was like a week ago or so, whatever. And then also had like heart surgery, and also had some other kind of like hypertension, hyperlipidemia, and other stuffs too. He started having this diarrhea like a week ago, and then it's been increasing. Previously it was like 2 to 3, now it's been 8 to 9 per day. Non-bloody diarrhea stool usually like doesn't float on the pan or water or whatever. And then you said, okay, is there any kind of fever with that? You're thinking about like infectious cause, you're thinking about chemo induced infectious cause or not. And then you will write, okay, that's what happened, that's what prompted the hospitalization, and he came into the emergency department, and what was done there. For example, in the ED he was like vitally stable, but something like, probably will say he had some hypotension, and he was given IV fluid, and then he improved probably. And then you say lab tests were done, like they did ABG, they did BVG. Sometimes whenever you have some diarrhea, they also like to do like CT test, so Clostridium difficile, so you can see all those studies. Sometimes if you have abdominal pain, we can do an abdominal x-ray. Sometimes we can do a CT scan of the abdomen if there is like a high suspicion of viscous perforation, not regarding to the diarrhea, but any other cause. So we can have all those diagnostic workup done in the ED, and you have to write those down in a summary so that you can describe it whenever you are presenting. Next, you will say, okay, and now that ED stabilized him, we admitted him to the floor, and now on the floor he's doing good. That's it. Now you will ask them about the history, like tobacco use, alcohol use, any other substance abuse, or his exposure history. For example, any kind of new like food or whatever, went to a barbecue or whatever, that can have like infectious cause of diarrhea. And then definitely you want to ask them how active are they at home. For example, some people are not really active, so like you can ask them about their daily ADLs. You're like, oh, do you usually do your groceries by yourself, or can you drive a car? So you just get an idea how active they are at home, because whenever whenever you will be discharging this person, you will be thinking about home, or if they're really weak, you can think about like physical therapy, physiotherapy and stuff. Okay, that's why you need to ask them that. Next is the review of system. So review of system meaning, so there is a chart. I think it's in the EMR system in every hospital possible. So there is a chart like a is there any kind of weight loss, fever, or whatever, so that you don't forget things. So sometimes you are like, sometimes patient forgot to tell you about a new rash that developed. Sometimes they forgot to tell you about any shortness of breath. So it's like for your safety and for patient safety, they have a review of system. Next you will ask them, okay, any past medical surgical history. Sometimes people can have like total colectomy. Sometimes people can have Roux-en-Y, whatever, like any related past medical history. Then any related family history, any like, and then all the obvious the current medication list, so that you know sometimes medication can cause diarrhea too, so that you rule out the medication induced diarrhea too. And that's your subjective. So whatever the patient is telling you and whatever you gather regarding the patient. And then you will straight go to objective finding meaning vital. So it's easy, you will see this. Then you will do a physical exam, and you will write those pertinent physical exam over there, and you also write the negative physical exams too. And then one of the important things that we usually don't do is drains, lines, and airway, we say. For example, some patients, like probably most of the cancer patient, they usually get chemotherapy, and they have a port in to give the chemotherapy, so that we don't need to like make an IV channel every time. So those like external lines are really susceptible to infections. So that's why you need to write those down so that you don't forget about it. Sometimes if the patient is coming with hypotension and they probably had fever, you think about like infection and stuff, you think about any line infection first. Yeah, those are the things that's like usually come. And then coming to the assessment and plan, and there is a little disclaimer for medical students. We like residents, we don't expect you to come up with all the plans and stuff at all. So if you can like have those history of present illness, past medical history, and objective data sorted out, I think for the first 2 or 3 weeks it's really good. And for the assessment of plan, we residents can help you with that. You should always ask the resident, or before presenting to the attending, you should always review those things with the like basically with your resident. For assessment and plan, always write relevant history. For example, you do a one liner, easy thing like 27-year-old male with past medical history of cancer, now on chemo, presenting here with diarrhea or whatever. And then you go with problem by problem. There are like multiple problems. For example, this guy is having diarrhea, so we don't know the cause of diarrhea yet. So there could be like infectious, this could be chemo induced, this could be any other cause. For example, he had underlined IBS or whatever, we don't know, right? So those will be your differential. And you will write for problem 1, diarrhea. Is it watery, non-bloody diarrhea? How many times a day? 8 times a day. Previous were 2 times a day. Pertinent history, got chemotherapy recently, no history of exposure. Then you will write differential meaning first is chemo induced, why, you will write the explanation. Recently got chemo, non-bloody watery diarrhea. That's it. Next is infectious, you will write, okay, he doesn't have any exposure history, but there are many things that we can be exposed to, for example like old food or whatever. So infectious is always a cause. And also the third will be like, I don't know, inflammatory. It's a 27-year-old guy can have IBS. Then plan. What would be the plan? For chemo induced, we cannot do anything. We just do like anti-diarrhea, loperamide. For infectious, we'll do like the GI panel testing, so virus, bacteria, and everything testing. If you're immunocompromised, you can test like oviparasite. If someone is on immunotherapy, you can think about like immunotherapy induced diarrhea. So in that case, you might order some kind of like lactoferrin, calprotectin. And for medical students, you don't need to know what the plan will be in a whole. You can just come up with like simple 1 or 2 things to think about. For example, like GI panel, for example IV fluid, for example antidiarrheal agent like loperamide. That's it. And then problem 2, for example, this guy has been having diarrhea for a week, so probably there is a chance that he might have AKI. So AKI, like prerenal AKI. So if you find that the like creatinine went up like greater than 0.3 like from the baseline, and then you can have AKI. Then you say, okay, AKI is prerenal, most likely prerenal. You say most likely prerenal. Why? Low PO intake, has been having diarrhea. And then you will do, and then that's your explanation. The plan would be, you will just continue the IV fluid, and then you will get a lab next day, and we'll see if it's improving or not. Then the problem 3, for example, problem 3 could be like the patient has diabetes, type 1 diabetes, who knows, and it's on insulin. Then you will just start insulin in the hospital. The third would be that's your problem list. Next is really important for a primary service. For example, if you are rotating at like intramedicine service, or if you are rotating as like any kind of primary service, then you can have different type of prophylaxis. So whenever a patient gets admitted to the hospital, we usually give some venous thromboembolic prophylaxis, because like thromboembolism is a really like a risky thing in the hospital, because the patient's not ambulatory, they're not moving around, they might have some thrombosis. The other thing is really important when you are doing when you are chatting with the patient, that you have to ask for code status for all of the patients who gets admitted to the hospital. Why? Because if something happens, like unlikely, but something happens, for example, they're having like kind of like coding meaning they're having arrest like PEA, then you have to do CPR, you have to intubate them. And so in that situation the patient cannot give you consent, so you basically take the consent prior to the situation. So these are like a common term we usually you ask the patient that okay, you can say don't be scared, I'm gonna ask you a really like common question that we usually ask people whoever is getting admitted to the hospital. If then you can say, oh, in an unlikely event, if your heart were to stop, do you want us to chest compress? That's your CPR. You said okay or no, whatever they think about it. And then you ask them again, if in an unlikely event, if your lung were to stop, do you want us to put a temporary, that's really important, a temporary tube down your throat to help you breathe? And sometimes people do not like, sometimes people like chest compression, most of the time people do not like a tube sucking through their throat. But you have to use the term temporary so that you don't think that it's a permanent tube. They're gonna have the code status, is it a full code, is it a DNR, or anything. And last thing but not the least is diet. For example, some people have kidney problems, CKD, you have to give them renal diet. Some people have heart problems, you have to give them heart healthy diet. Some people that they have no like any other comorbidity, so you can just give them any kind of food you want, regular diet. Some people have religious things, then you have to do all this type of religious diets too. So if you do all those things, like small things like prophylaxis, core status, diet, that people like international medical graduates and miss a lot, you will be really appreciated by your resident. For how do you write an HnP, not present. Okay, so in the next video I'll give you some details about how to present an HnP. Okay, take care, bye bye.